Hello, I'm Dr. Kim Yong-jin. Last time we talked about the customized titanium mesh, the Builder, which can be connected to implant. Various cases were discussed. In this lecture, I will talk about the Builder 3 or Jawbuilder that can be selectively used in a wide-ranging bone defect area. This is more advanced Builder. So let's have a look at it. Generally, Builder can be connected to an implant, a titanium mesh that can address simple bone defect. But as I said before, if we have a wide-ranging horizontal or vertical bone defect where implant cannot be easily placed, delayed approach can be used to generate bone using a Jawbuilder or Builder 3. As you saw before, there are two types that can be used for severe horizontal or vertical defects. Depending on the mesiodistal lengths, there are two options, 10 millimeters and 20 millimeters. So in total, 4 sizes are available. The general Builder is generally used when implants are placed. After implant is placed, over the implant, the middle structure called anchor is connected to connect the Builder. So Builder 3 or Jawbuilder can be used when implants are placed. However, when the defect is quite large, hard to achieve the implant stability, how can we use the Builder? For that, we need tenting screws in place of the implants. This is not just conventional tenting screws. Its superstructure is the same as the form of the anchor screw. So when implants cannot be placed, tenting screws for Builder should be connected and the bone graft is done, and Jawbuilder can be used on top of it. To connect the Builder or Jawbuilder to the tenting screws, cover cap or healing cap are used, just like the Builder connection. So when implant cannot be placed, you need to drill a hole so that tenting screws can go in. After that, bone grafting is done. Based on the tenting screws, the Jawbuilder would be connected. Let's look at a case how it is used clinically. A 40-year-old female, she had a traffic accident, so upper left incisor was extracted. Due to the trauma and the extraction, there is a severe labial bone resorption. Pre-op photo, as you can see, the adjacent teeth papilla looks okay, but labial bone plate is lost a little bit. So she wanted very highly aesthetic implant prosthesis, so we decided to use the delayed approach. The flap is opened, and in this patient, we can place an implant immediately, but the patient did not want it, so we decided to do bone regeneration first to make the contour. So we decided to place the tenting screws instead of implant and use a Jawbuilder. In the Builder kit, you can see the drills exclusively for tenting screws using the drilling. The drilling is done on a sound bone to get a primary stability. You don't have to drill full depth. The tip of the tenting screw is very sharp and designed for self-tapping, so drilling is to mark a point. A tenting screw is placed. After that, around the tenting screw, bone graft is done. For bone graft, the ideal bone housing should be made for later placement of implant. So bone graft materials are positioned even outside the extraction window. Sandwich technique is used. Allograft in the extraction window and low temperature sintered xenograft like AOs outside is put in for overall augmentation to maintain the space and to form ideal alveolar bone housing around the implant, a Jawbuilder is used. The Jawbuilder is not the vertical augmentation type, but horizontal augmentation type, primarily to augment buccally. A small Jawbuilder is used. The mesiodistal distance is 10 millimeters, as it is for a single implant. The Jawbuilder is fixed over the tenting screw with the cover cap. This case, as you're watching right now, it is the tenting screw with the external connection type. Now, internal connection type tenting screws are available. The primary closure is achieved. This is the panorama and PA post-op. Let's look at CT, how the form is made. Post-op CT. As you can see, the Jawbuilder has the contour of ideal alveolar bone form. If the bone is formed like this, placing an implant would be easy. Let's look at how it is healed. 3-month healing. Adjacent natural teeth papilla is very well maintained, and you can see the horizontally augmented labial bone. Post-op 4 months, the Jawbuilder is removed and implant will be placed. It is healed. On the occlusal view, we can see the augmented alveolar bone volume. The flap is raised and the vertical incision line is not made because the Jawbuilder is fixed over the tenting screw with a cover cap, so vertical incision is not necessary. Horizontal incision and the circular incision near the adjacent teeth were made. Flap is raised and Jawbuilder is removed. Removing the Jawbuilder is the same as removing Ausbuilder. Cover cap or healing cap is removed. If a flap is raised along the Jawbuilder, it can be easily removed. Jawbuilder is removed and the ideal bone is regenerated below. In the form of the Jawbuilder, the tenting screw can be easily removed as it has the machined surface. After removing the tenting screw, additional drilling is done to place an implant. The implant is placed. After the placement, you can see the implant path and angulation. The primary stability is very good, so healing abutment was connected, completing the surgery. Post-op panorama and PA. CT after placing the implant. As you can see, outside, the low temperature sintered EOS xenograft was positioned, so it is not resorbed, and the augmented labial bone volume is very well maintained. So when the defect is very wide-ranging and unfavorable, or more stable bone regeneration is desired vertically or horizontally, this special type of Ausbuilder, the Jawbuilder, can be a good option to use. Let's have a look at another case where it can be used. The reason why I prepare this case is that in a case where conventional titanium mesh can be used, but when we use the Jawbuilder, I want to show you how implant placement can be made easy, so we can compare those two. 45-year-old female, chief complaint due to severe period disease. Overall, there is teeth mobility and a defect at number 26 and 27. First, upper right posterior teeth are extracted due to severe mobility. Waited until soft tissue healing. In the meanwhile, 2 implants are placed at number 26 and 27. And prostheses were delivered after occlusion is established in the left posterior. Now, the right implants need to be placed according to the plan. On the panorama, The right side of the patient has vertical bone loss, but we cannot tell how much bone loss there is. If you look at here, there is vertical wide-ranging bone defect in both quadrant 1 and 4. We need to do ideal vertical bone augmentation to come up with ideal prosthesis. The vertical bone defect volume would be more than 3 millimeters. When do we need to use a titanium mesh versus general GBR using general membrane? For vertical bone augmentation, it depends on the volume of vertical bone defect. According to many studies, block bone graft versus titanium mesh technique versus GBR using particle bone material and membrane. Depending on those, the amount of vertical bone regeneration can differ. Titanium mesh technique and block bone can grow 5 to 6 millimeters of vertical bone, but GBR using particle bone graft material and the conventional membrane can grow 3 to 4 millimeters of vertical bone. In this case, the patient has the bone defect more than 4 millimeters before surgery, so titanium mesh or block bone would have better predictability, so we decided to use titanium mesh. At about 4 months after extraction on the upper jaw, the bone is healed. There is no lesion or mucosa thickness in the sinus. There is both vertical and horizontal bone defect due to severe prior period disease. The upper occlusal view, healing at 4 months after extraction. Let's look at mandible. The mandible also has the vertical bone defect and horizontal buccal bone defect. First, the operation on the upper jaw using titanium mesh to augment the vertical bone defect. 2 vertical incisions and crystal incision are made. Flap is raised. As we saw in the pre-op CT, the residual bone in the posterior region to the sinus floor is only 2 to 3 millimeters. So lateral window approach is used to lift the sinus membrane and to perform sinus bone graft. The window is removed. The sinus membrane is lifted, and inside allograft bone graft material is packed. After that, the removed window is repositioned. In the maxilla, conventional titanium mesh is used. The flat titanium mesh, the mesh is cut and bent to make a contour. The standard titanium mesh is to be fixed with bone screws. The bone screws included in the OSTEM's GBR kit are used to fix the membrane or titanium mesh. 2 screws are used to fix the buccal apical area. So first, stable adaptation is made apically. In the defect, the autogenous bone from tuberosity is put in, and outside, the xenograft material, sintered at low temperature, is used to make the contour. Bone graft materials are positioned to augment vertically and horizontally for ideal alveolar bone form. And then the graft materials are covered with the titanium mesh. On the palatal side, it is fixed with the bone screws. The standard titanium mesh is different from general membrane as it has poor adaptation capability. As titanium mesh is metal, if it is not fixed, things below it will move. So the bone graft material would be exposed or will be unfavorable for bone regeneration. So what is important for titanium mesh is stable fixation. So standard titanium mesh would be fixed with the bone screws. The disadvantage of titanium mesh is exposure. To minimize it, we need to draw blood from a patient to make a PRF to cover the edges where exposure is a concern, and the entire titanium mesh is covered with the OS-guide, the collagen membrane, so everything is covered. The purpose of it is to prevent the exposure, and the buccally releasing incision is made for the flap, and the primary closure is achieved, which is important for GBR as well as the bone augmentation using titanium mesh. After operation on maxilla lateral view, you can see vertically augmented alveolar bone. Now it's time to operate in mandible. 2 vertical incisions and crystal incision are made, and the flap is raised. On the upper jaw, all teeth 14, 15, and 16 except 17 had a big vertical bone deficiency, and the bone quality was poor, and the distance to the sinus floor is extremely limited, hard to achieve primary stability, so it is not possible to place implants. But we could place implants in mandible at number 46 and 47 before performing bone augmentation. So we placed 2 implants at 46 and 47. The vertical bone defect exists between those 2 implants in the mandible. We can use the standard titanium mesh in the mandible, but we decided to use the Jawbuilder to make it easier. So a tenting screw is placed between implants, and the Jawbuilder will be connected to the tenting screw. So over the implants at number 46 and 47, vertical bone augmentation will be done. Using an auto bone collector from the ramus distal to 47, from the buccal area, autogenous bone is harvested and is mixed with xenograft material 1:1 ratio between number 46 and 47 implants. The tenting screw is placed to connect to the Jawbuilder. The tenting screw's head, where the Jawbuilder will be mounted, should be superiorly positioned than the cover screws of the adjacent implants. Only that way the overall alveolar bone can be augmented vertically. And the bone graft materials are positioned on the cortical bone where blood supply is poor, so cortical perforation is done. According to Dr. Picos, in the mandibular posterior, not only the buccal flap but lingual flap can be advanced coronally. Using a finger like this, you can dissect the lingual flap below the mylohyoid ridge. The lingual flap can be advanced coronally a little bit. When you do GBR for vertical augmentation in mandible, lingual flap dissection can achieve the primary closure rather easily. That is the benefit. If you use an instrument, sublingual artery or lingual nerve can be damaged. So if you use an index finger to do blunt dissection below the mylohyoid ridge, lingual flap can be advanced. So first the lingual flap is dissected and the site is covered with the bone graft material and tenting screw is positioned. Autogenous bone and xenograft are mixed together. This is unlike the previous case. Vertical augmentation type Jawbuilder is used, which is 20 millimeters mesiodistally because the defect area is long mesiodistally. After that, as you can see, the patient's gingiva biotype is very thin, so there is a risk of exposure. Just like OS-Builder, the Jawbuilder is preformed and there is no line angle area, less exposure risk, but gingiva biotype is thin, then edges can be exposed. To minimize it, OS-guide membrane covers the site. Next, the primary closure. After mandibular operation, the lateral photo, if you see it here, in both jaws, vertical alveolar bone is augmented. If you compare before and after, in both jaws, vertical bone defect was 4 millimeters or over. Post-op photo shows that vertical bone augmentation has achieved. Post-op panorama and PA. CT of maxilla. Titanium mesh. The standard mesh is bent and applied. As you can see, the titanium mesh is fixed using a screw buckley. In the mandible, the Jawbuilder has the contour of ideal alveolar bone form buccally and lingually, and bone graft material is positioned below it. At post-op 4 months healing, the maxillary titanium mesh is not exposed and the Jawbuilder in the mandible is not exposed. After that, in the mandible, Jawbuilder will be removed first because in the maxilla, sinus bone graft was done using lateral approach and the bone quality was not good, so we decided to wait for about 5 months. For the mandible, 4 months would be enough for bone regeneration because the defect size in the mandible was smaller. To remove the Jawbuilder, only horizontal incision, crestal incision is made, not vertical incision. As I said before, to fix the Jawbuilder, only a cover cap is used. The flap is raised and the cover cap is removed that fixed the Jawbuilder, and the Jawbuilder is removed. As you can see, the ideal bone is regenerated buccally and lingually just in the form of the Jawbuilder. And vertically, bone is regenerated. The driver used to fix the tenting screw is reversely rotated to remove the screw. It is easily removed. After that, healing abutment is connected and keratinized gingiva needs to be increased buccally, so apically positioned flap is also performed. After that, 5 months after operation, the final prosthesis in the mandible is completed and titanium mesh is to be removed in the maxilla. The maxillary titanium mesh is not exposed up to 5 months after operation. Unlike the Jawbuilder removal, titanium mesh needs to be removed by making 2 large vertical incisions because the screw used to fix the titanium mesh is apically positioned, so the incisions should be made just like the first operation. The flap is dissected, 2 screws are removed, and the titanium mesh is removed. You can see bone is regenerated. The lateral view, the titanium mesh is bent. The vertical and horizontal bone is augmented according to the contour of the mesh. After 5 months, even though bone regeneration is sufficient, the regenerated bone is still not matured, so the pattern of the bone marrow is unstructured, and therefore undersized drilling is recommended. Still, the remodeling process is going on, so the implant should be placed rather deeply, not 1 millimeter but 1.5 millimeters below. Cover screws are connected because the stability is not satisfactory and the primary closure is done. Number 17, implant placed in the first operation. Healing abutment is connected to it. The lateral view, panorama and PA after the placement. Let's compare before and after. The vertically augmented alveolar bone volume is very well maintained. I show you this case to show that Jawbuilder is easy to use and easy to remove. In order to remove it, the standard titanium mesh requires 2 vertical incisions and a wide-ranging flap dissection. But for the Jawbuilder, at the beginning, 2 vertical incisions are required. However, to remove it, you don't need that. For a surgeon, Jawbuilder is much more convenient to use, and it is convenient to remove it as well. To fix it, for standard titanium mesh, bone screw is necessary, but it is not the case with the Jawbuilder. If you select cases appropriately, it can be used very easily. Panorama after delivering the final prosthesis. Clinical photo. This lecture we talked about more upgraded Jawbuilder that can be used in wide-ranging defect area, Jawbuilder 3, which is a Jawbuilder. I don't use Jawbuilder quite often because we don't have a lot of patients today with wide-ranging defects. But if you understand the characteristics of Jawbuilder and how to use it, you can have a good option to address defects in a patient that can not be easily tackled with a standard titanium mesh. Titanium mesh itself is a very good material and very good membrane. However, many doctors are not using it because when complications occur, it is hard to address and the frequency of the complications is high. But OSTEM launched the Jawbuilder, the Jawbuilder, which has maximized the benefits of titanium mesh and increased the convenience or ease of use, and also overcoming limitations of standard titanium mesh. And if you use the membrane appropriately, that can be a very good armamentum. Thank you for your listening.